Community-Acquired Pneumonia by Taylor Mills, Grace O'Brien, Emma Shug, Edwina Marco, and Ada Morley. As evidenced, a concept map was developed to clearly identify all areas of community-acquired pneumonia. Links between all components of community-acquired pneumonia have been identified and marked. Pathophysiology, risk factors, signs and symptoms, diagnostic testing, clinical management, medication management, and complications were all included and linked appropriately. The following slides will deliver further detail into these areas, how they are interlinked, and their relationship to community-acquired pneumonia. Community-acquired pneumonia, also known as CAP, is defined as pneumonia that is acquired in a person outside of hospital or healthcare facilities. It is an acute infectious inflammation of the lungs in which fluid accumulates in the alveoli. The infection causes the lung air sacs, also known as the alveoli, to become inflamed and fill up with fluid or mucus. The etiology surrounding pneumonia is due to causative organisms including bacteria and viruses. It can also come from fungi, however that is a less common type of pneumonia. There is a pathophysiologic process that occurs with community-acquired pneumonia. Organisms may enter the respiratory tract through inspiration or aspiration of oral secretions. Normal pulmonary defense mechanisms such as the cough reflex, mucociliary apparatus, mucus secretion, and nose hairs that usually protect against infection are compromised. In susceptible hosts, these defenses are either suppressed or overwhelmed by the invading organism. The invading organism multiplies and releases damaging toxins in the alveoli, causing inflammation and edema of the lung functional tissue. This results in accumulation of cell damage. Once the cells in the alveoli are damaged, the lung tissue fill with exudates and fluid changing from an airless state to consolidated state, thus decreasing gas exchange. This pathophysiology manifests in signs and symptoms with both modifiable and non-modifiable risk factors prevalent. Community-acquired pneumonia relevant signs and symptoms can only be managed once diagnostic testing is completed. Non-modifiable risk factors. Age is a risk factor for community-acquired pneumonia, specifically the elderly, those above the age of 65, and young children, those below the age of 2 or born prematurely. Deteriorating physiological changes accompany the aging process. Their weak immune system lack basic defense mechanisms, leaving the elderly vulnerable to infection. Elderly with existing health issues such as dementia can experience difficulties in salivary elimination of bacteria, swallowing, and aspiration disorders. These deficiencies in mucus clearance increase the risk of community-acquired pneumonia. Similarly, children aged below 2 years or born prematurely present with weak immune systems not strong enough to fight off infection, therefore are at risk of community-acquired pneumonia. Gender is another risk factor for community-acquired pneumonia. Males present higher incidence rates in community-acquired pneumonia than women. Studies have found that estrogen boosts the ability to fight off bacteria, thus women pose less risk. Aboriginal Torres Strait Islander people are also more likely to suffer from pneumonia than non-Aboriginal and Torres Strait Islander peoples. Modifiable risk factors. In accordance with modifiable risk factors, smokers are 2 times more likely to develop community-acquired pneumonia than non-smokers. Tobacco smoke decreases mucus clearance, therefore increasing mucus production. As a result of pneumococcus bacteria colonization, the innate immune system response to bacterial infection is suppressed. Alcohol abuse decreases adaptive immunity and is relative to increased respiratory infections and pneumococcus bacteria, therefore increasing the risk of community-acquired pneumonia. Poor dental hygiene is also a risk for community-acquired pneumonia. As dental plaque colonizes, inflammatory molecules such as cytokines can form and thus transmit to the lungs. This stimulates the inflammatory process that occurs in community-acquired pneumonia. Comorbid conditions such as chronic obstructive pulmonary disease predispose and increase risk for community-acquired pneumonia. In COPD, mucus hypersecretion promotes bacterial colonization in the lungs, fueling an onset of community-acquired pneumonia. In light of this, asthma is a risk factor for community-acquired pneumonia due to weaknesses in lung function and tissue. Diabetes mellitus is a risk factor for community-acquired pneumonia as it predisposes people to various infections. Studies have reported diabetes patients have increased incidence rates in developing community-acquired pneumonia compared to non-diabetic patients. Other lifestyle factors such as occupational exposure to toxins and sudden temperature changes and crowded living conditions are considered risk factors for community-acquired pneumonia. Airborne transmission from others diagnosed with community-acquired pneumonia can similarly increase the risk. Often signs and symptoms of pneumonia can be mistaken for that of a cold or flu. Patients commonly present with 1 to 2 days of a cough, fever, dyspnea, fatigue, rigors, and pleuritic pain, all due to the lungs changing to a consolidated state. A patient's cough can be dry and persistent or productive, with both producing green or yellow sputum, and occasionally appearing rusty or containing small amounts of blood. This is due to a buildup of fluid and exudates in the lungs. Fever is often high grade in children, resulting in constant sweating and cold shivers, also known as rigors. Fever occurs as the body's defense mechanisms work to attack and kill the causative organism. Dyspnea means a shortness of breath, often noted on physical exertion. Shortness of breath can lead to deprivation of oxygen in the body, resulting in confusion or disorientation. This is particularly common in the elderly or people with chronic diseases. Oxygen deprivation occurs due to damaged alveoli and can be indicated through colour change of patients' lips and nails. Patients may develop white nail syndrome, otherwise known as leukonychia, where the nail bed turns white in colour. This may in turn also be noted with lips turning a pale or bluish tinge. In severe pneumonia, cyanosis of the nails and lips may occur. As the immune system works to kill the causative organism, people can become tired and fatigued. Fatigue includes muscle pain, headache, overall weakness, lowered energy levels, and poor appetite. Fatigue can be dangerous in elderly patients as it may cause frequent falling. Pleuritic pain is noted via prickling or dull aching chest pain, which may worsen, resulting in difficulty breathing and/or coughing. Respiration of patients with community-acquired pneumonia is commonly distinguished by tachypnea, with rapid crackles audible on inspiration and sometimes evidence of pleural effusion. Inflammation and damage of the alveoli and lung cells cause a decrease in diffusion of oxygen into the blood, causing the body to become tachypneic as it tries to compensate for oxygen loss. Pleural effusion can be noted by dullness on auscultation or a lack of ribcage expansion on respiration. This occurs due to the fluid and exudate buildup in the lungs. Community-acquired pneumonia can be diagnosed through the completion of a comprehensive pneumonia assessment, which includes obtaining objective and subjective data from the patient. A pneumonia assessment allows the medical professional to use their clinical judgment and knowledge to determine if the patient has community-acquired pneumonia. It includes gaining information that could suggest the immune defense system of the airways has been weakened and allow for the pathophysiology of pneumonia. Subjective information from the patient will include their health history, current medications, any recent surgery, and modifiable and non-modifiable risk factors. The objective information will include all the presenting signs and symptoms. A pneumonia assessment also includes conducting a respiratory assessment. The nurse will listen for audible crackles on the lungs, which could suggest secretion in the bronchial airways as a result of infection. Tools such as the Curb scale can be used in addition to determine the severity of the pneumonia. A pneumonia assessment allows for key clinical features of pneumonia to be observed, so a management plan can be put in place early based on the diagnosis. Another diagnostic test for determining whether or not a patient has community-acquired pneumonia is through a chest X-ray or other similar forms of imaging. The X-ray will focus on the lungs, heart, and surrounding blood vessels. White spots, also known as infiltrates, will appear on the X-ray if infection is present. X-ray imaging will therefore reveal the functional pattern of the infecting organism and is therefore important in the diagnosis of pneumonia. An X-ray will also be able to determine whether there are any complications as a result of pneumonia, such as fluid surrounding the lungs and abscesses. Patient history and examination, along with a chest X-ray, is often enough to make a diagnosis of community-acquired pneumonia. A third option in the diagnostic testing of pneumonia is to obtain a sputum sample for culture and gram stain. This is ideally done before the commencement of antibiotics, as they can interfere with the results. The patient will be asked to cough deeply and expel their sputum into a container for testing. In the laboratory, the sample of the sputum will be placed on a slide and stained with a special agent. The sample will then be placed under a microscope to observe for signs of infection. In the case of pneumonia, the gram stain would reveal bacteria with thin cell wall, commonly referred to as the gram-negative bacteria. White blood cells would also be observed, indicative of infection. If the sputum sample is sufficient enough and pneumonia is still suspected as a result of the gram stain, the sample will then be sent for culture and sensitivity tests to determine the type of bacteria causing the infection. The most common bacteria seen in the cases of pneumonia is Streptococcus. Other more invasive methods of diagnosing community-acquired pneumonia include obtaining arterial blood gases for observation and obtaining a full blood count to observe for high levels of white blood cells. Clinical management for a patient with community-acquired pneumonia involves maintaining a clear airway, assessing the patient's respiratory rate and effort of breathing, and auscultating the lung sounds using a stethoscope, noting the quality. As noted in signs and symptoms, secretions in the large airways can produce rhonchi or coarse lung sounds. Similarly, note any signs of wheezing or high-pitched stridor sounds, as these are indicative of airway obstruction. If the patient is coughing, note if it is wet, dry, or barky, as this is a sign of pneumonia. Educate the patient on coughing and breathing techniques to minimize tachypnea and dyspnea, thus reducing respiratory distress. Frequent hydration is similarly important in clearing the airway of any mucus. If the patient is unable to clear the airway, suctioning and/or providing nebulized medication liquefies these secretions, making it easier for the patient to cough. Additionally, nurses must assess if the patient is receiving adequate oxygen. Confusion and abnormal speech are signs that the patient is hypoxic. Therefore, nurses must assess the patient's alertness and mental state. Monitor blood oxygen and arterial blood gases. Reduce fevers and promote rest in order to slow down metabolism and reduce consumption of oxygen. Elevating the head of the patient's bed also allows gravity to expand the lungs, thus providing more surface area for gas exchange. If these interventions see no improvements in oxygenation, providing oxygen and/or intubation is necessary. If the patient requires low-flow oxygen, nasal prongs, Hudson mask, parietal rebreather masks, and non-rebreathers are sufficient. Pneumonia patients requiring high-flow oxygen therapy, greater than 15 litres per minute, can be administered through a Venturi mask, which delivers a fraction of inspired oxygen concentration between 24 to 55%. Managing infection involves monitoring the patient's level of dehydration and conducting frequent sets of vital signs. In essence, a fever is suggestive that infection is present. Assess secretions for colour and thickness and evaluate effectiveness of antimicrobial therapy. Practicing appropriate infection prevention and control is also vital. Antibiotics such as macrolides or doxycycline can similarly be used to treat infection. Similarly, ensure the patient is adequately nourished and hydrated. Observing oral tolerance demonstrates whether the patient is aspirating. Finding the patient's baseline weight and nutritional status is also indicative of the patient's progression while in hospital. Provide meals and schedule interventions and medical procedures outside of these meal times. Other assessments involve monitoring the patient's inputs and outputs, providing IV fluids if necessary, and noting skin turgor. If an area of pinched skin remains pinched for over 3 seconds, the patient is likely to be dehydrated. In the form of medication management, nutritional therapy can promote increased energy levels and adequate nourishment. This will be discussed further in the next slide. Finally, clinical management of community-acquired pneumonia involves monitoring the patient's level of pain, specifically chest pain. Conducting PQRST assessments and providing comfort measures such as sleep are examples of preventative pain interventions. Teaching relaxation and splinting techniques, such as pressing a pillow over the patient's stomach, is utilised to minimise the discomfort and pain that results from coughing. Also administer analgesics or antitussives if charted. As such, clinical management involves reassessing after every intervention, noting any deterioration and promoting patient-centred care. The first treatment step of community-acquired pneumonia is empiric, using antibiotics containing macrolides or doxycycline to inhibit formation of bacteria and to fight the bacteria already existing in the body causing the illness. Identifying the causative organism of pneumonia in patients is essential in establishing the correct antibiotic for the patient. If diagnosis is off, it prolongs recovery as medication will likely need to be altered. Patients who are hospitalised are usually administered their antibiotics parenterally, but should be switched to oral antibiotics once they are afebrile and symptoms have improved. Most cases of community-acquired pneumonia in otherwise healthy adults do not require hospitalisation, and therefore oral antibiotics are administered based on a suspected infecting organism. Macrolides are the ideal therapy to kill infection, including either azithromycin or roxithromycin. For patients who are allergic to macrolides, doxycycline is the preferred treatment. In addition to macrolides, patients may take a respiratory fluoroquinolone such as levofloxacin or moxifloxacin, combined with an advanced macrolide and high dose amoxicillin. In addition to medication therapy, patients should aim for a fluid intake of approximately 3 litres per day to compensate for increased loss due to fever or rapid breathing. If oral intake cannot be maintained, IV fluids and electrolytes should be considered for an acutely ill patient. Small, frequent meals are ideal for patients, and they should aim to intake about 6,300 kilojoules per day to provide and maintain energy for increased metabolic processing occurring in the body. This is essential in treating and reducing the symptoms of fatigue. Complications often occur in people suffering community-acquired pneumonia, however, are most common in the following circumstances. When diagnosis is delayed due to late presentation, there is an incorrect initial diagnosis, or the wrong choice of initial antibiotics is made. Complications are also more common in the elderly and people with underlying chronic illnesses. The main complications that may arise are as follows. Pleurisy is a common complication that develops from inflammation of the membrane around the lungs brought on by pneumonia and may progress to pleural effusion. Pleural effusion is a build-up of excess fluid between pleural layers outside the lungs, resulting in what people refer to as water on the lungs. This can lead to shortness of breath, chest pain, and a cough as previously discussed during the signs and symptoms slide. Approximately 1% of children diagnosed with pneumonia develop pleural effusion. Pneumothorax may occur, which is when air leaks into the space between lung and chest wall and causes the lung to collapse. A collapsed lung is associated with a dry and persistent cough as noted in signs and symptoms. A bronchopleural fistula is an abnormal passageway that develops between the bronchi and the pleural cavity, leading to uncharacteristic air leaks. The complications mentioned so far are reported in up to 53% of children hospitalised with community-acquired pneumonia. Further possible complications include developing a lung abscess or empyema. The difference between these two being that an abscess is an infection within the lung, whereas an empyema is a pus-filled cavity within the lung. Both generally develop due to inadequately treated pneumonia, as a result of bacteria replicating and causing damage to lung tissue. These complications can take approximately 4 to 8 weeks to heal. Complications that are more prevalent in adults suffering pneumonia and are more long-term than previously mentioned complications include hypotension resulting in severe hemodynamic changes and cardiac complications such as myocardial infarction and heart failure. Acute respiratory failure is another possible complication and may result in alveoli and cell damage in long-term pneumonia sufferers. Community-acquired pneumonia may cause local and systemic inflammation, leading to a dysregulated host response, eventually resulting in sepsis, multi-organ dysfunction, septic shock, and death. Other complications that may arise include mild confusion, mild jaundice, arthritis, and mild anemia, although these rarely have clinical consequences. Mild confusion occurs due to oxygen deprivation stemming from dyspnea, as previously discussed in the signs and symptoms slide.